So I will not wait for any persons and I will start. Today we will learn an important topic, especially in the Autacoid Pharmacology, that's the non-steroidal anti-inflammatory agents, or in simple what we can call them as the NSAIDs. So these class of the drugs are very commonly used in veterinary practice, human practice, as well as the other living beings for reducing the pain, fever and inflammation. So these agents are very useful, and we will learn them in detail. So what are the non-steroidal anti-inflammatory agents? Yes, all drugs grouped in this class have analgesic, antipyretic and anti-inflammatory activities. So analgesic means the pain reducing property, antipyretic means the fever reducing property, and anti-inflammatory means the inflammation or swelling reduction properties. These drugs have got all the three properties. So in contrast to morphine, they do not depress CNS. That's one of the important thing. Morphine is also an analgesic and anti-inflammatory agent, but it is CNS depressant, and these agents do not produce physical dependence and have no abuse ability and are weaker analgesics except for inflammatory pain. So when compared to the morphine depresses the central nervous system, induces the sleep and produces the physical dependence, means the persons get addicted, whereas non-steroidal anti-inflammatory agents are the modern class of the drugs which reduce the pain, fever and inflammation. So they are also called as non-narcotic, non-opioid or aspirin-like analgesics. So aspirin is the first agent in this class, hence they are called as the non-narcotic, means not inducing the sleep, and non-opioid means they are not belonging to the group of the morphine and aspirin-like analgesics. So they act primarily on peripheral pain mechanisms, but also in the central nervous system to raise the pain threshold. So these agents are acting on the COX-2 inhibitors, and the NSAIDs will be inhibited, and the prostaglandin production will be inhibited at the same time other inflammatory agents. And apart from this one, these agents are also going to increase the pain tolerating capacity, that is they are acting on the central nervous system to raise pain threshold. So they are more commonly employed, and many are over the counter drugs. Over the counter drugs means the example is the paracetamol and aspirin, etc. They are available without the prescription of a qualified physician. So over the counter drugs, and nowadays it is one of these drugs are one of the most popular drugs in management of the pain and pyrexia. The willow bark, which is of a plant Salix alba, had been used for many centuries, and the salicylic acid is the first product prepared by hydrolysis of the bitter glycosides obtained from the particular Salix alba, and sodium salicylate was used for fever from about 200 and more years back, that's 1875. Then it is great success led to the introduction of the aspirin, acetyl salicylic acid or aspirin, in 1899, and the phenacetin and antipyrin were also produced the similar type of the effect. The next major advance was development of phenylbutazone in 1949, having anti-inflammatory activity and almost compatible to corticosteroids. So the anti-inflammatory activity of these agents was very similar to that of the corticosteroids. So we have got so many drugs, the corticosteroids, non-steroidal anti-inflammatory agents, and if the pain is very severe, then morphine derivatives. The term non-steroidal anti-inflammatory drugs, NSAID, was coined to designate such drugs, especially the inhibitors of the PG synthesis. Indomethacin was introduced in 1963, and apart from this one, many new agents have been discovered recently and are used in the human as well as the veterinary practice. Then a host of the compound heralded by the propionic acid derivative, that's the ibuprofen or ibuprofen, have been added since they are the cyclooxygenase inhibitors and recognized to be the most important mechanism of the action. So, cyclooxygenase is the enzyme which is very much required for the synthesis of the prostaglandins and leukotrienes, which are the mediators of the pain. So, this pathway is inhibited. Then sequentially some selective COX-2 inhibitor like celecoxib, rofecoxib and have been added to this category, very preferential. There are very many varieties of the COX-2 inhibitor, preferential COX-2 inhibitor and specific COX-2 inhibitors. So, these agents are being invented nowadays and are very popular in nature. Of course, the classification is like that. There are 4 classes A, B, C and D. A is the non-selective COX inhibitors, or they are the traditional or old NSAIDs. The example is the salicylates. In the group of the salicylates, the aspirin is the classical example of non-selective COX inhibitor. They are acting on both COX-1 and COX-2. The second one is the propionic acid derivatives. The example is the ibuprofen, naproxen, ketoprofen, flubiprofen, etc. So, they are the propionic acid derivatives. And phenamates, the mefenamic acid is the classical example of the phenamates. And enolic acid derivatives are the pyroxicam, tenoxicam, etc. and meloxicam. So, the enolic acids and the acetic acid derivatives are ketorolac, indomethacin, that is the nebumetone. All these are the classical example of acetic acid derivatives. And pyrazolone derivatives are the phenylbutazone, oxyphenbutazone are the classical examples of the pyrazolone derivatives. The second one is the preferential COX-2 inhibitors. So, they are also acting on the COX-1, but the action on the COX-2 is more. So, these drugs are nimesulide, diclofenac, aceclofenac, meloxicam and etodolac. So, these are the preferential COX-2 inhibitors. Whereas, the selective COX-2 inhibitors are celecoxib, etocoxib and pericoxib. So, all the coxibs are very selective COX-2 inhibitors. Whereas the another classification D is analgesic antipyretics with poor anti-inflammatory action. So, para-aminophenol derivatives, just like the paracetamol, which has got very good antipyretic activity, whereas the anti-inflammatory activity is very minimal. So, paracetamol is also called as acetaminophen. And pyrazolone derivatives like metimizole, or the name is dipyrone and propiphenazone. So, these are all the classes of the drugs. And benzoxazosine derivatives like nefonam and the other drugs. And this is the classical classification of the drugs, and one has to remember these drugs like salicylates, preferential COX-2 derivatives, selective COX-2 inhibitors, analgesic antipyretics, etc. So, this is the flow chart how NSAIDs have been classified as the non-selective COX inhibitors, like the older cyclooxygenase inhibitors are older agents like the salicylate, acetyl salicylic acid, acetic acid derivatives like the indomethacin, nebutamine and ketorolac. Whereas the same thing earlier we have learned pyrazolone derivatives, oxybenzone, phenylbutazone, whereas the propionic acid derivatives like mefenamic acid. Whereas the phenamates are mefenamic acid, propionic acid derivatives are ketoprofen, tobuprofen, ibuprofen. It's one of the important agent, especially used in dental surgeries or dental induced pains. So, the enolic acid derivatives are pyroxicam and tenoxicam. So whereas the preferential COX-2 inhibitors they are acting on both COX-1 and COX-2, whereas they have got more affinity towards the cyclooxygenase 2. So the examples are the nimesulide, diclofenac, aceclofenac, meloxicam and etodolac. Whereas the selective COX-2 inhibitors are celecoxib, etarocoxib, parecoxib. So analgesic antipyretic with poor anti-inflammatory actions. The classical examples are the acetaminophen or paracetamol and metimazole and propylphenazone, nifopam. So all these points are very important. The name NSAIDs are the agents which are used to get relief of the pain, inflammation and fever, and as per the COX pathway, the COX-1 and cyclooxygenase 2 are the two pathways which produce prostaglandins which initiate the pain and the inflammation. So this is the flow chart with example. Please remember this particular chart. This will be very useful for the future remembering of this class of the drugs, and especially this is useful and remember that this table is need to be mugged up also. Whereas here in this particular table and the classification of the NSAIDs with chemical nature. So here you can see that so many these NSAIDs, especially the initially COX-1 inhibitors or non-selective inhibitors, like they have got the aspirin and other drugs, especially they have the better analgesic and antipyretic activity and poor anti-inflammatory type of the activity. So here in this one you can see more COX-1 in this first half. We can see that these drugs which spotted here do have more COX-1 selective activity, and if you come to the right side, then it is the more selective COX-2 inhibitors. So ketorolac, then flumipropane, ketoprofen, etc. till the sodium salicylate are the more selective COX-1 than the COX-2. Whereas the meloxicam, diclofenac, celecoxib, rifacoxib and lubirocoxib, they are very specific COX-2 selective inhibitors. Whereas in the third table you can see that the plasma half-life, that's the T half. So diclofenac has got the very short half-life, whereas the celecoxib, rifacoxib, etarocoxib and pyroxicam and or meloxicam, they have got the longer half-life of the 60 hours. Of course, this is 10 hours and short as 1 hour, the earlier diclofenac and other NSAIDs. So coming to the chapter NSAIDs and prostaglandin synthesis inhibition. So in the earlier chapter NSAIDs, we have learnt that the cyclooxygenase pathway is leading to the production of the prostaglandins and also the thromboxins A2 and leukotrienes. So all these are the inflammatory mediators. In 1971, Wayne and co-workers made the landmark observation that aspirin or acetyl salicylic acid and some NSAIDs blocked prostaglandin generation. So this is now considered to be the major mechanism of action of the non-steroidal anti-inflammatory agents. The prostaglandins, prostacyclin and thromboxane A2 are produced from the basic acid, that's the arachidonic acid, which is lipid derived autacoids, and the enzyme cyclooxygenase. So the enzyme cyclooxygenase exists in two forms, that is the cyclooxygenase 1 and another one inducible cyclooxygenase 2, and the cyclooxygenase 1 serves the physiological housekeeping function, means scavenging action on the body. That's the cyclooxygenase 1. Especially the later one, that is the cyclooxygenase 2, it is present in very small quantities. It is induced by the cytokines and other signal molecules at the site of inflammation, leading to the generation of the prostaglandins, and locally they are going to be produced, which mediate many of the inflammatory changes. Whereas the cyclooxygenase 2 is it's present ubiquitously throughout the body, but also it's present in the brain, juxtagranular cells, and in the fetus also the COX2 is present. And if it may serve physiological role at these sites, and most NSAIDs inhibits both cyclooxygenase 1 and 2 non-selectively. But nowadays the recent generation non-steroidal anti-inflammatory agents are very specific COX2 inhibitors. And in this chart we can see that whenever there is a cell membrane damage or hit or any injury, then there is a release of membrane phospholipids from the cell membrane, especially in case of the animal cell, and the phospholipase A2 is going to act on the phospholipids, then it is converted to the arachidonic acid. So arachidonic acid, in presence of the enzyme cyclooxygenase, it is converted to prostaglandins, whereas with the lipooxygenase it is converted to leukotrienes, and it is going to have the chemotactic axis. Whereas the prostaglandins, they have got many type of the inflammatory reactions, starting from vascular permeability changes, ocular inflammation, the vasodilatation, meiosis, then intraocular pressure changes, the inflammation, and many more type of the responses are mediated by the prostaglandins, especially prostaglandins F2 alpha, PGI2, PGE2, and leukotrienes. Of course, the lipooxygenase is going to give the pathway to leukotrienes. Yes. And here also you can see that this is arachidonic acid, then it is from the cell membrane, this with the help of the phospholipase A2 enzyme, the arachidonic acid is formed. Then arachidonic acid in presence of cyclooxygenase and 1 and 2, it is going to produce the inflammatory mediators, like varieties of the inflammatory mediators, means thromboxines synthesis, thromboxines, and PGI2 and PGH2 and PGF2, PGD3, PGF2, and so many varieties of the prostaglandins, and they are all the mediators of the inflammation. And here once again it is noted that whenever there is a cell damage is there, then cytokines are produced with the help of the enzyme. That is the membrane bound enzyme, that is the arachidonic acid, which is acted by cyclooxygenase and lipooxygenase, then prostaglandins and leukotrienes. So the cell damage is leading to cytokines, that's interleukin 1, interleukin 6, and tumor necrosis factor alpha. So whenever there is a cell damage, once again the membrane phospholipids are released with the help of the phospholipase A2. The corticosteroids also inhibit phospholipase A2 and they are reducing the pain. Whereas the phospholipase A2 is acting on the arachidonic acid, and the cyclooxygenase 1 and 2 are leading to PGG2, PGH2, then the prostacyclins, PGF2 alpha, PGE2, and PGG2 is converted to thromboxines A2 and thromboxane B2, and all these are the inflammatory mediators. So apart from this one, the leukotrienes are formed, leukotriene A4, leukotriene B4 and C4 are formed, whereas the leukotriene C4 to leukotriene D4 and leukotriene E4 are formed. All these in combined with, they are the very good inflammatory agents which are required for the body. But when the action of these interleukins, leukotrienes, then especially the prostaglandins is exacerbated, then the animal is suffering from lot of pain, and we are going to pharmacologically inhibit the cyclooxygenase 2 so that all these prostaglandins are not produced. And of course, the corticosteroids are inhibiting in the upper phase, that is the phospholipase A2. So this is a very brief diagram how the cell damage causes the phospholipid, membrane phospholipid release, and membrane phospholipids are converted to the arachidonic acid. The arachidonic acid in presence of the endogenous COX-1 and the COX-2, which is inducible. COX-1 are going to produce the PGH2, especially in the stomach, kidney, endothelial and platelets. Whereas the COX-2 is an enzyme which is inducible, produces PGH2, and apart from this one, it is produced from the monocytes, fibroblasts, syncytiocytes and chondrocytes, all these pathways and target tissues of the COX-1. So this is endogenous one. In every cell this is happening whenever it is subjected to a damage or the phospholipase A2. Once again, please remember the phospholipase A2, which converts the membrane phospholipids to arachidonic acid, and corticosteroids are the one which are going to inhibit this pathway. Hence, corticosteroids are also anti-inflammatory agents. And platelet activating factor. So the phospholipase A2 is leading to PAF, platelet activating factor. So this is also inhibited by the corticosteroids, whereas it is not affected by NSAIDs, as NSAIDs are going to affect the COX-1 and the COX-2 enzymes, and also 5-lipoxygenase pathway, which produce the some inflammatory agents. So the leukotrienes and thromboxanes are, and also the prostacyclin PGI2 and prostaglandins are PGE2, PGF2 alpha and PGD2 are the prostaglandins, and these are the very important sources of the pain and fever and inflammation. So once again, this chart is related to the membrane phospholipids. So phospholipase A2, arachidonic acid, which is arachidonic acid is converted to the prostaglandins and leukotrienes and the thromboxanes. So cyclooxygenase pathway converts them to prostaglandins, whereas the thromboxanes are also produced, whereas the lipoxygenase pathway they are going to produce leukotrienes and bradykinin, and hence the ketoprofen etc. they are going to act on this particular site. And features of NSAIDs, that is the non-selective anti-inflammatory COX inhibitors and selective COX inhibitors. Like the COX-1 and COX-2, they are non-selective, the first generation agents, they are acting on both, whereas the celecoxib, rofecoxib and the recent generation agents like meloxicam etc., they are the preferential COX-2 inhibitors. There the analgesic property, both have got the analgesic property, antipyretic, of course these have got both antipyretic property and anti-inflammatory, both COX-2 inhibitors and COX-1 and COX-2 non-selective inhibitors. Of course, the antiplatelet activity is stopped by the COX-1 inhibitors, whereas COX-2 they do not have on the antiplatelet aggregatory activity, whereas the COX-1 and COX-2 inhibitors they have got all these properties. Gastric mucosa damage, the COX-1 and COX-2 inhibitors, since PGI2 is the one which is involved in the PG2, involved in the production of the gastric mucosa or mucin. So the renal salt water retention is caused by the COX-1, whereas 2, it is inhibitors are very less frequently involved. Ductus arterioscloser, so COX-1 and COX-1 are very good agents, and aspirin and sensitive asthma agents, especially the COX-1 and COX-2. COX-1 and COX-2 inhibitors are going to affect on the asthma precipitation, whereas the COX-2 are not going to affect. And aspirin inhibits the COX irreversibly by the activity letting one of its serine residues return of the COX activity, and it depends upon the synthesis of the fresh enzyme. The other NSAIDs are competitive, reversible inhibitors of COX, and return of activity depends upon their dissociation from the enzyme, which in turn is governed by the pharmacokinetic characteristic of a particular compound. So, what is the beneficial actions of the PG synthesis inhibition? The number 1 is analgesia, the prevention of the pain from nerve ending sensitization, whereas the antipyretic activity or reducing the fever, that's also another important thing, and anti-inflammatory activity is very much helpful, and antithrombotic and closure of ductus arteriosus in case of the newborn. So, all these are affected. And coming to the analgesia, PGs or prostaglandins, already we have learned that these induce hyperalgesia, means more and more pain sensation, by affecting the transducing property of free nerve endings, so that stimuli that normally do not elicit pain are able to do so. So, whereas the PGs are also involved in sensitization of the peripheral nerves for the pain, and NSAIDs do not affect the tenderness induced by direct application of the PGs, but block plain sensitizing mechanism induced by the bradykinin, tumor necrosis factor alpha, interleukins and other analgesic substances, and this action is mainly attributable to the inhibition of the COX-2 enzyme. This constitutes the peripheral component of the analgesic action of the non-steroidal anti-inflammatory agents. So, they are therefore more effective against inflammation associated with the lot of pain, and now we can manage the pain better than the earlier. So, some of the central components of analgesic action of NSAIDs also been shown to involve inhibition of the PG synthesis in spinal dorsal horn neurons as well as in the brain. So, they are also inhibiting the cyclooxygenase pathway or some other unknown pathway which is going to inhibit the PG synthesis and reduce the pain. And the antipyretic activity or antipyresis, the NSAIDs reduce body temperature in fever but do not cause the hypothermia in normothermic nature. That is very important. In case of the increased fever only or the increased temperature only, they are going to act. On the person who is having the normal temperature, these NSAIDs are not going to reduce it to below normal or subnormal. And fever during infection and tissue injury is produced through the generation of pyrogens, including the interleukins, tumor necrosis factor alpha, interferons, and which induce PGE2 production in the hypothalamus and raise its temperature set point. So, antipyresis is caused. NSAIDs block the action of pyrogens but not that of the PGE2 injected into the hypothalamus. So, this isoform at site appears to be usually the COX-2 possibly, and some of them are maybe COX-3 also. And the third activity is anti-inflammatory activity. The most important mechanism of the anti-inflammatory actions of the NSAIDs is considered to be the the inhibition of the cyclooxygenase 2 mediated enhanced prostaglandin synthesis at the site of the injury. Whenever there is an injury, then lot of the prostaglandins are produced, and if NSAIDs are given, then it is going to act on the cyclooxygenase pathway, and there will be reduced prostaglandin synthesis and there will be reduced inflammation. However, the inhibition of the constitutive COX-1 also contributes to the suppression of the inflammation. Both of these are involved in the pain management, especially the anti-inflammatory potency of different compounds roughly corresponds with their potency to inhibit the COX. However, nimesulide is potent anti-inflammatory but relatively weak COX inhibitor. So, the PGs are only one mediators of inflammation, one of the inhibition, and the inhibition of COX does not depress the production of other mediators which are from the lipoxygenase pathways like leukotrienes and platelet activating factors and cytokines. They will be produced. So, prostaglandins cannot inhibit the pain to the extent of the 100%. And inflammation is result of concreted precipitation of the large number of vasoactive, chemotactic and proliferative tissue factors and different stages, and are the many targets for the inflammatory agents. And this activated endothelial cell expresses adhesion molecules, that is the ELAM1 and ICAM1 in their surface, and play a very important key role in directing circulating leukocytes to the site of inflammation. That is known as the chemotaxis, means attracting the chemically induced moieties to the site of inflammation. And similarly, inflammatory cells express selectins and integrins. There are the two substances, and some NSAIDs may act by additional mechanisms including inhibition of expression activity of some of the molecules and generation of the superoxide and other free radicals. The growth factors like GM-CSF, interleukin 6, as well as the lymphocyte transformation factors and tumor necrosis factor alpha may also be selected. Stabilization of leukocyte lysosomal membrane and antagonism of certain actions of the kinins may be contributing to the NSAID action. So, apart from simple production of prostaglandins, many other agents like the interleukins, tumor necrosis factor alpha and cytokines, they are also participating in the process of pain and inflammation. So, for the effective management of the pain, we have to learn the action of individual agents in a thorough manner. So, antiplatelet aggregatory NSAIDs inhibit the synthesis of both pro-aggregatory, that is the thromboxane A2, and anti-aggregatory, that is the PGI2 prostanoids. But effect of platelets, that is the thromboxanase 2, which are generated by the COX-1, it predominates especially. And therapeutic doses of most of the NSAIDs inhibit platelet aggregation, and bleeding time is usually produced because of the thromboxane A2 inhibition. And aspirin is very highly effective. That is why the aspirin is the drug of choice for the cardiologists. So, it is highly active and acetylates the platelet COX irreversibly in the portal circulation before it is deacetylated by first fast metabolism in the liver. That is why the aspirin is a very commonly used drug, and small doses are therefore able to exert anti-thrombotic effect for several days. That is why the cardiac physicians or cardiac surgeons always prescribe the aspirin, even though it has got the lot of side effects of the gastric ulcer production and the increasing the bleeding time, and risk of surgical and anticoagulant associated bleeding is very much enhanced. Even then, it is having the action of the antiplatelet activity. and especially in case of the newborn ductus arteriosus closure during the fetal circulation. Ductus arteriosus is kept patent by local elaboration of the PGE2 by COX2 enzyme. So, if you use this COX2 inhibitor, then the ductus arteriosus closure may be hampered, and unknown mechanisms switch off this system in birth and ductus arteriosus closes. When this fails to occur, small doses of indomethacin or aspirin bring about closure in the majority of the cases within a few hours by inhibiting PG production. That's in the case of small newborn kids, this is a very problematic. The ductus arteriosus in the heart is not going to close. So, whenever you use small doses of indomethacin and aspirin, which are very specific selectors of the COX1 pathway, and administration of NSAIDs in late pregnancy has been found to promote premature closure of the ductus in some cases. Means, suppose in a family there is a history that the delayed closure of the ductus arteriosus is there, then the pregnant woman themselves can be given administered with NSAIDs, so that the early closure of ductus arteriosus occurs in the offspring, and risk of postpartum hemorrhage is increased, and prescribing of NSAIDs needed term should be always avoided. So, postpartum hemorrhage may be increased because of the decreased clotting time. And parturition, sudden spurt of PG synthesis by the uterus occurs just before labor begins, and this is believed to trigger labor as well as facilitates its progression. So, accordingly, non-steroidal anti-inflammatory agents have the potential to delay and retard labor. So, if you administer NSAIDs in case of a cow which is about to parturiate, then it can prolong the parturition or delay and retard labor. However, labor can occur in absence of the PGs also. So, of course, the PGs are required for the labor, but if you inhibit the PGs, of course, the labor can occur in absence of PGs also. And gastric mucosal damage is always a problem in case of the non-steroidal anti-inflammatory agent action, that is the inhibition of COX1 mediated synthesis of the is a gastroprotective PGs, especially the PGE2 and PGI2 are involved, whereas the gastric pain, mucosal erosion, ulceration and blood loss are produced by all NSAIDs to varying extents. Relative gastric toxicity is a major consideration in the choice of the NSAIDs. And inhibition of the COX1 mediated synthesis of the gastroprotective PGs is clearly involved, and there is this is by local action inducing back diffusion of hydrogen ions in the gastric mucosa also play a very important role, and PGE2 and PGI2 are the two important prostaglandins that's inhibited by COX1. So, hence whenever the NSAIDs like the aspirin etc., the earlier generation are given, the COX1 is inhibited, whereas the production of the mucin as well as the production of bicarbonate is inhibited by the PGE2 and PGI2 inhibition. And deficiency of prostaglandins reduces the bicarbonate secretion, tends to enhance acid secretion and may promote the mucosal ischemia. So, the PGI2 and PGE2 are very much required for the secretion of the bicarbonate ions, which neutralizes the gastric HCl, and hence it is inhibited by the NSAIDs, and hence the erosions and ulceration occurs. Thus, NSAIDs enhance the aggressive factors and contain defensive factors in gastric mucosa, and ultimately they are all the ulcerogenic, especially the agents, first generation agents are the very much ulcerogenic in nature. Whereas the paracetamol is a very weak inhibitor of the COX-1 and is a practically free of gastric toxicity, and selective COX-2 inhibitors are relatively, they are very safer. And paracetamol, of course, the crocin and other tablets, they are the weak inhibitors of the cyclooxygenase and are practically free of the gastric toxicity, and selective COX-2 inhibitors. When the stable analogs, just like the PG analogs, means they are very similar to that of the prostaglandins, just like in the earlier chapter we have learned that the misoprostol administered concurrently with NSAIDs counteract their gastric toxicities. Misoprostol, it's an antagonist of the, it's an agonist of the PG, and if you administer them simultaneously, they are going to antagonize. There is a term known as the analgesic nephropathy. It occurs after years of heavy ingestion of analgesics. So, such individuals probably have some personality defect. So, this analgesic nephropathy occurs after years of heavy ingestion of analgesics. Maybe in patients who are suffering from the gout or the type of the pain originated from the bone. And regular use of combinations of NSAIDs and chronic repeated urinary tract infections increases the risk of analgesic nephropathy. And pathological lesions are papillary necrosis, tubular atrophy, followed by the renal fibrosis. This is known as the analgesic nephropathy. And urine concentrating ability is lost and the kidneys will shrink in size, and because phenacetin is the first implicated, it went to dispute, and through the other analgesics are also liable to produce the similar type of the analgesic nephropathic effect. And sometimes anaphylactic type of the reactions also observed. Aspirin participates asthma, angioneurotic swellings or edema, urticaria or rhinitis in case certain possible individuals. And these subjects react similarly to chemically diverse NSAIDs, ruling out immunological basis for the reaction. And inhibition of COX with consequent diversion of the arachidonic acid to the leukotrienes and other products of lipoxygenase pathway may be involved. So, the lipoxygenase pathway and cyclooxygenase pathway are the two different ones, which the lipoxygenase pathway produces leukotrienes, whereas the cyclooxygenase pathway is going to produce the prostaglandins and the interleukins and many more, or cytokines. So, these are all the agents especially the NSAID is authorized to be used in cattle with registered routes and uses, just like the flunixin, it's a pour-on preparation, especially the milk need to be withdrawn for 36 to 7, and it has got the respiratory disease, mastitis and infectious food disease. Whereas the meloxicam is one of the very commonly used NSAID in veterinary practice. So, the route of administration of this drug is subcutaneous and IV. The milk should be withdrawn for 120 hours, means about 5 days the milk need to be withheld, whereas the meat need to be withheld for the 15 days. So, the treatment recommended from the meloxicam is mastitis, diarrhea, pneumonia, and after disbudding also the meloxicam can be very successfully, it can be used. Then another thing is the tolfenamic acid, it can be used as subcutaneous and IV, whereas if you administer the drug either by both the routes, then the milk withdrawal period is 24 hours, that is 1 day. whereas the meat withhold days is 3 to 7 in different routes. And carprofen, it is subcutaneous and IV. There is no milk withholders, and also the meat withholders are about 21 days. Milk, it is not secreted in the milk, whereas the flunixin, meloxicam, tolfenamic acid, then all these are secreted in milk, and hence the particular milk should be withheld. And ketoprofen, it is administered as IM and IV, so no milk need to be withheld, whereas the meat should be withheld for minimum a day of either 1, 2 or 4. So this can be used in case of mastitis, pneumonia, post-parturient inflammation, musculoskeletal disorders, lameness, injuries, and many more inflammatory conditions. So the approved drug in case of veterinary, please remember this one: flunixin meglumine, meloxicam, tolfenamic acid, that's the carprofen and ketoprofen. All these 5 drugs are very commonly used in veterinary practice. So these are the authorized drugs. And use of the NSAIDs in veterinary practice. So very important use of the NSAIDs in veterinary practice is for the treatment of the mastitis. I think you might have seen in this thing everywhere. This is mastitis, maybe the meloxicam. Can be used in mastitis, diarrhea, pneumonia, and many more conditions. These can be used. For peracute mastitis, products that can be given intravenously are preferably ideal, just like meloxicam, but there is no evidence that one product is better than other. So one has got the advantage over the other thing. So we need to see about whether it's a beneficial or having certain risk. In milder cases, treatment with NSAIDs can reduce pain and inflammation more effectively than antibiotic alone. So the antibiotics, no doubt they are to be given, but apart from the antibiotic therapy, the NSAID therapy is going to help a lot. In mild cases, meloxicam has been shown to reduce both somatic cell count and the impact of mastitis on fertility, especially in case of large studies. And similar effects have not been reported for the other NSAIDs, especially, but it's possible that they would also produce similar type of effect, like to reduce both somatic cell count and especially the mastitis induced pain. So the use of meloxicam in mild cases is economically beneficial, but the significant addition to the cost of treatment seems likely to be a barrier of more widespread use. So the cost of meloxicam is more when compared to the regularly used NSAIDs, so this is going to add to the mastitis treatment. But apart from this one, it is one of the very good agent to treat the mastitis. And lameness, it's a very common problem in case of the horse. If a horse becomes lame, means it is not at all useful for any purpose. Then the pain associated with lameness lasts for about 28 days after the successful treatment and probably starts at least 28 days before the diagnosis. So the pain, especially in case of the horses, makes them unfit for the racing. Hence, NSAID should be standard treatment in cows treated for lameness, even if the lameness is chronic. And also these NSAIDs can be used to minimize the pain, and the lame cows should be treated as early as possible by trimming, blocking, and NSAIDs. And the ketoprofen has the most recommended agent in lameness management, followed by the meloxicam and the carprofen. Especially the ketoprofen and meloxicam, they can be administered if the cow is limping, and also if the horse is limping. That's the drug of choice, ketoprofen. And of course the other drugs like the meloxicam and carprofen, both are commonly used in case of the cows and approved also. And cough pneumonia is one of the very common clinical sign in case of the cough. So the NSAIDs alone combined with the close monitoring is a useful alternative to antibiotic treatment in milder cases. Of course, this NSAIDs can be used for the treatment of the inflammation of the lung. Then short acting NSAIDs may be as effective and cheaper than the longer acting products and allow the treatment regimen to be more flexible. So if long acting antibiotics are being used along with less close monitoring, then long acting NSAIDs can be used so that the cattle are not being handled just to administer the NSAIDs. So these are some of the important points in case of the different animal diseases which can be controlled with the administration of NSAIDs. And in case of this hoof deformities and the pain induced by the hoof deformities, we can see that the NSAIDs like the ketoprofen, they are very commonly used to control the pain. And whereas in case of the cough, diarrhea and cough pneumonia, also varieties of the NSAIDs are having lot of importance. And coming to the first agents, especially the salicylates, they are known as the aspirin is a classical example of the salicylates, and it is a acetyl salicylic acid, and it is rapidly converted in the body to salicylic acid, which is responsible for most of the actions. And other actions are the results of acetylation and certain macromolecules including the cyclooxygenase, and it is one of the oldest analgesic anti-inflammatory drug. So aspirin is the oldest analgesic anti-inflammatory drug and is less frequently nowadays. It's because of the for this purpose, especially anti-inflammatory and analgesic activities, because whereas it is very commonly used in case of the cardiac treatment, especially the cardiac ischemias, it is as it is having the action of less thrombosis, then it is having the action. So this is the structure of the salicylic acid: COOH, OH and OCH3 aspirin. And the pharmacological actions of the NSAIDs are the analgesic, antipyretic and anti-inflammatory actions. And aspirin is a weaker analgesic, has lower maximal efficacy than morphine type of the drugs. So when compared to the morphine, aspirin is not a very good analgesic, and however it effectively relieves inflammatory tissue and injury related connective tissue and integumental pain, but it is ineffective in severe visceral and ischemic pains. Whereas the other drugs like the meloxicam and of course pyroxicam, many more drugs are effectively used in case of the visceral or hollow organ pain. So the analgesic action is mainly due to the peripheral pain receptors are abducted and the prevention of PG mediated sensitization of nerve ending. And apart from this one, a central subcortical action raising threshold to the pain perception is also contributes, but the morphine like action on psychic processing of reaction component of the pain is missing by the NSAIDs. And there is no sedation occurring, and subjective effects, tolerance or physical dependence is usually there. It is not produced when compared to the morphine and other derivatives. So the aspirin resets the hypothalamic thermostat and rapidly reduces the fever by promoting heat loss or sweating and due to the vasodilation, but does not decrease the heat production. So heat loss is rapidly it is reduced. Aspirin resets the hypothalamic thermostat center, especially it is acting on the central nervous system and switching up of the thermostat and rapidly reduces the fever by promoting heat loss. So more and more heat is lost and does not decrease the heat production. It is not decreased. The metabolic effect of the aspirin are significant only at the anti-inflammatory doses. In lower doses it is not anti-inflammatory. In higher doses it causes that particular effect. And the cellular metabolism is increased, especially in the skeletal muscles, due to the there is increased utilization of the glucose, and blood sugar may be decreased, especially in diabetes, and liver glycogen is depleted. However, hyperglycemia often occurs at toxic doses. So there is a slogan called as a statement called as aspirin induced hyperglycemia. This is due to the central sympathetic stimulation and release of the adrenaline and corticosteroid. And the chronic use of the large doses cause negative nitrogen balance by increased conversion of protein to carbohydrate, and plasma free fatty acid and cholesterol levels are reduced. Respiration, of course, the effects are dose dependent. At anti-inflammatory doses, respiration is stimulated by peripheral increased carbon dioxide production, as well as the central or COX, this central carbon dioxide inhibition. And hyperventilation is prominent in case of the salicylate poisoning. It is a very common thing, the salicylate poisoning, and the further rise in salicylate level causes the respiratory depression. Death is due to the respiratory failure, especially in case of toxicity of the aspirin. And coming to the kinetics of these products, aspirin is absorbed from the stomach and small intestine. It is poor water solubility is the limiting factor for the absorption and microfining the drug particles, and however the higher pH also favors the ionization, and more ionized, then they are excreted in the urine. So the bound to plasma proteins to the extent of both aspirin and salicylic conjugated liver glycine to salicylic acid. It's a siluric acid. It's a major pathway, and they are also conjugated with the glucuronic acid, and the metabolites are excreted by glomerular filtration and tubular secretion. And normally only 1/10 is excreted as free salicylic acid, but it can be increased by the alkalization of the urine. And the plasma half-life of the aspirin is 15 to 20 minutes, very short half-life, and it is the salicylic acid, that is the metabolite, is 3 to 5 hours. And our adverse effects, we will deal it. Tomorrow it has got lot of side effects also, and the adverse effects of course are very common. So adverse effect of the salicylates are very common, and in many time we are seeing this is the greatest